Next, it is my pleasure to reintroduce Dr. Kriegsmann and also to introduce Dr. Kilpatrick and Dr. Ryzewicz for our inpatient addiction panel.
Thank you again, everybody, for joining us. Welcome to our live harm reduction conference inpatient panel discussion. What we're going to do over about the next half hour is we're going to start off with some cases and really talk through a couple of the more difficult things that we see, and then hopefully actually incorporate some of your questions into this. So for the attendees participating, if you do have questions during this, please type it in as you've been doing to the chat, and we'll do our best to get to it. I'd like to start by introducing our panel. First, Dr. Steve Ryzewicz, who's the director of the Inpatient Addiction Consult Team at Baystate Medical Center. Next, Dr. Jay Kilpatrick, who's a consultant liaison psychiatrist who specializes in addiction psychiatry and is the director of the Inpatient Psychiatric Consult Team at Baystate Medical Center. And finally, Dr. Ari Kriegsmann, who we just heard from in that amazing lecture, who is director of the Inpatient Addiction Consult Team at Mercy Medical Center. Thank you all very much for joining us today. It's great to see everybody. So, as medical providers, let's start with a case, because that's how we learn by cases. We're starting with a 35-year-old man with a history of opioid use disorder who was admitted the night before with an abscess and cellulitis. Patient uses 2 bundles or about 20 bags of heroin a day, and he's used that for the past year. And his last use was the night before he was admitted to the hospital. Otherwise, he's healthy with no allergies and not on any other medications. In the emergency department, he only received ibuprofen for pain and clonidine, 0.1 milligrams, for withdrawal. You approach the patient the next morning, you see that he's anxious, yawning, sweaty, and as soon as you walk in, he almost immediately says that he wants to leave. I'll start with you, Steve. This is, I think, a common patient that many inpatient providers see. What is your approach? How do you first approach and talk to this patient?
Okay, thanks, Bill. First, can you hear me all right? Is it coming through? Okay, great. Yes, obviously, this is a extremely common type of presentation in the acute hospital setting. I had prepared some brief remarks about this case, which I'll go through. And it's funny, as I was listening to the previous lectures today, I realized how many of the points that I wrote down for myself have been touched on in different ways. So I'm very heartened and glad to hear that other experts in the field and have similar thoughts and approaches in some ways. So obviously, we have to put ourselves in the position of the patient. They are sick, they're feeling ill, they're terrified. This particular patient is miserable at that point, and obviously in some withdrawal. And probably that's the sole focus of this person's existence right now, is how do I get out of withdrawal and be able to be more comfortable. And similar to what I think some of our earlier presenters had today, one of the most important things initially is to make a connection with the patient. The anonymous walking in the room, hi, my name is Dr. blah, 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 and what's your problem, or something like that, it's just not going to fly. You need to really clearly identify your role with the patient. Say your name, say their name, identify them, make an initial connection. In the days before COVID, we would shake their hand too, at least give them a virtual handshake or something just to make sure that you made that initial connection with them. And really identifying your role, because people roll in and out all day long. They've got masks on, they've got goggles on, you can barely see their faces, especially now. And often the patients are too miserable to even bother trying to look at a badge. I tend to point out my badge if they want to read it. Some squeeze their eyes shut and don't want it, they don't care. Others look in. And I think it's important to identify that role. If you're the attending physician or the primary provider in the hospital, you might want to mention that and make them aware that you've read through the chart, you've got some basic understanding of what brought them here to the hospital, and also what at least other people have said about their opioid use disorder history. But then I always emphasize to the patients, but I want to hear from you. I want to really make sure that other people haven't misstated things, and I really want to know your view on things as well and what you see as your opioid use disorder history and what your current situation, what your recent situation is, and have kind of let them open up about that in, as open-ended a way as you can initially. Now, many patients will have preconceived notions based on past bad experiences or good experiences on what different providers may understand about addiction medicine or addictions in general. Some may just dismiss you out of hand before you even get a chance to say anything. And so that's why I think if you're a provider who does have some familiarity with it, go ahead and say so right up front and give them some comfort that you know what you're talking about, or at least are in a reasonable position to be able to help them realistically and not be someone who's not going to really be able to do anything for them. And as one of the previous presenters said, if you really don't have a lot of experience and you are on uncertain terms, it's okay to be honest with the patient. Just say, look, I want to gather some information. I really want to understand as best I can. You can educate me about your specific condition, and then tell them you'll be happy to get some additional expert consultation in to help get the ball rolling on getting you feeling better as you can. Then once you've made that initial connection and sort of established where you are and you get some of the history, it's always, for somebody who's in acute withdrawal like this, and this guy was getting up and ready to leave AMA pretty soon, you can't spend too much more time doing anything else right now. You need to really acknowledge openly that, recognize their uncomfortableness and how miserable they appear. Give them some reassurance that you see what's going on and how bad it is for them. And give them some assurance that you're going to try everything you can that's possible to get them to feel better as quickly as you can. You'll have to say, look, I need some basic information. Just work with me for a few minutes here, because I don't want to just accept blindly what other people have told me. And things are sometimes not written down exactly accurately. But once I get through that basic stuff, we're going to move to get you better or feeling better as best we can and quickly as we can. And then around that point, it's reasonable to at least get a night. Let's say it's opioid use disorder, they're in opioid withdrawal. You can ask them, what's worked well for you before? How has your withdrawal been treated in previous hospitalizations? And how long ago might that have been? And what have you learned about what works best for you? Patients know, and they can often give you they might say, oh yeah, they gave me 30 of methadone the last time I was doing it in 2 hours, and can we please do that? Okay. Sometimes they're right. You have to really, make sure you know what you're talking about. The phrase was mentioned earlier, to meet them where they're at. I think that's really important in that initial connection. If the patient just kind of closes their eyes, rolling around on the bed, they're trying to ignore you, they don't want to answer any of your questions, well, so be it. You're not going to be able to right then talk about, would you be interested in suboxone down the road or methadone down the road and maybe a recovery coach and maybe et cetera, et cetera. You need to just focus on managing the acute withdrawal and figuring out the best way to do that and what will be the most effective way to do that. So, and you shouldn't really assume anything until they confirm as best they can with you what's going on. And the last thing on this question is, before you even go in the room, you should really know what they've been getting so far. Because if you walk in knowing nothing, you came in a day or two ago and I don't know what they gave you. You'll have egg on your face and mud on your boots. You won't really be able to have you'll lose some validity and some credibility. So it's good to know what's already been given and what's not working.
I think that's great. And some of the key points that I really came away with that, again, it's what we've been emphasizing. It's talking to them as people. It's preparing yourself before you go in. And then I think the thing that you mentioned, which I really liked, is recognizing how uncomfortable this can be and thinking about it in terms of it's an urgency, right? It's not something to say, well, I have to get through this because this is the only time I'm going to see you, so we're going to talk for an hour. It's, I see you're uncomfortable. I'm going to deal with it. I understand that this is very uncomfortable, and I have the power to deal with it. I wonder, Steve, thinking about, we have a lot of providers attending who aren't addiction trained, but will be that person maybe to start those first medications. As you're coming into this person, what treatments are you offering, or what are you thinking about offering this person?
So first off, it's always okay, and most of the time before other doctors from the specialty service are involved, almost like a standing order set will be people offering symptomatic treatments. So you'll have hopefully clonidine ordered with some dosing interval, maybe a non-steroidal anti-inflammatory agent if a patient can safely take those, possibly even Tylenol in some cases, even though that helps some but not a lot, and antidiarrheals for the bowel symptoms, things along those lines. At least those basic things hopefully were ordered before, maybe by the an ER staff initially, or the person doing the admission H&P, who may have not been focused on withdrawal yet because maybe they didn't see a lot of withdrawal just yet. But when you're picking that patient up, say, the next morning, and the withdrawal is ongoing, hopefully some of those things have already been ordered. If not, you can go ahead and order them because they can be supplemental to things. But probably one of the biggest, I'll give you one small bulleted point, which a quote that I've made up for myself, and I don't know if I'm stealing it from anyone else. Ready? Here it is. Quote, 30 milligrams of methadone can be a beautiful thing, unquote. And from what Dr. Kriegsmann said, I think in his lecture, he agrees, it sounds like. It's incredible. And really in this last year when I've been doing much more of this as part of the addiction consultation service, I'd never before seen it so often work so well. So for patients who can take methadone, and even if, there's all this concern, oh, what was their outpatient dose if they had one? Oh, what's the QTC? Oh, we can't confirm things with the clinic. Oh. All those barriers, they almost all can melt right away. Maybe not the QTC issue, okay, but all the can't confirm, don't know, it's almost always safe to give a 30 milligram dose of methanol, and you will be amazed at how wonderfully different this patient will look in most cases just within a couple hours, okay? And then you see the real person. You don't see this writhing, uncomfortable thing almost, that I was talking about earlier. So, of course, you need to make sure that it's not totally contraindicated, and make sure the QTC prolongation is not a big issue. Make sure that they haven't got such a mental intoxication or a polysubstance overdose or something like that that would make you not be able to do it. But when you can give it, it's a wonderful first step. Now, that having been said, if you have given symptomatic treatments and those have not worked, or you don't want to wait for those because you don't think they're going to work so well, and you don't want to do methadone for whatever reason, or you can't do methadone, you can consider suboxone as well. Now, suboxone, obviously, the way we induce patients in the outpatient onto suboxone is when they're in acute withdrawal. So if you've got a patient who's in acute withdrawal in the hospital, you can certainly use suboxone for that as well. Now, you always have to worry, though, about precipitated withdrawal, which has been mentioned earlier. You don't really know how many, they may be in some withdrawal, but how many opioids are still floating around in there, and you might precipitate withdrawal. But really, if they're in quite obvious opioid withdrawal, you should be able to get away with starting suboxone. But then what often happens is the patients may have a direct say in this matter, and here's where you have to educate them. Some patients come in and they are absolutely convinced, no way, I never want to be on methadone. It's just, all those biases we've heard earlier. It's just substituting one drug for another. I've seen so many people that are doped up on that stuff, and it's awful to come off of. They may have a lot of preconceived notions, but it's always it's appropriate to reassure them that, hey, even if I use methadone to treat your acute withdrawal, which I can almost guarantee is going to help quite a bit, that doesn't commit you to long-term methadone treatment. That doesn't mean you're going to end up in a methadone clinic going in at 5:30 every morning for the rest of your life. This is just temporarily in the hospital, get you through the acute withdrawal, and then when you can have a more intelligent, calm, rational discussion with me or others about this, we can see what's going to make the most sense going forward. And similarly with suboxone, it doesn't mean you have to do it forever.
I think that's a really great point, Steve. I think there can be a lot of, for folks that don't treat addiction, a lot of fear about these. We are told to fear methadone, and to have some guidance to say, yes, you have to respect these things, but also there is safe dosing, and there is the ability. And by giving someone one dose to help treat them, you are not committing them to their lifetime of having this. That this is really treating them where they are at, and it can be revisited. It's a really important point. I want to quickly open it up to others. Ari, go ahead.
Yeah, I was really struck by that. I've had the same experience as Steve. So many people I've met who come in like, I don't want methadone, never want it again. Reframe it as, hey, we just want you to be comfortable here in the hospital so you can stay and be comfortable, get the treatment that you need. And they agree to a taper, and then they get a dose of methadone, be it 15, 20, 30 milligrams, and then you have another conversation with them 2 hours later, and they're in a much different place. And I think some of the hyperarousal and the defenses that have been there that just pop up, drop down, and you can actually have a meaningful conversation. I've been struck by how many people have later agreed to actually go on to maintenance, who were like in the beginning hard set against it, agreed to a taper, But then after they got a dose, you can actually really have a conversation.
And that's a great point, because I think it gets to what we've talked about earlier as far as seeing the behavior not as the person, but seeing it partially as their disease process, right? If they are in acute withdrawal, then that affects different things like decision making and other capacities where you need to get them to that stable place. And then, Steve, as you said, then it's the time to have the conversation with it. Totally agree. Yeah, Jay, please.
A wonderful point about methadone. It's amazing how many providers are comfortable giving clonidine or something for cramps or other things for comfort measures. And then, we'll be frightened to also give the 15 or 20 milligrams of methadone. But I just want to echo that I've also seen this effect, and it can prevent a person from leaving the hospital. On the psych consult service, we get so many consults for patients who want to leave AMA, and we have to see if they have the capacity to do so. We've been able to stop that just by giving a small dose of methadone or buprenorphine. It can keep someone from leaving the hospital, and I want to encourage, the safe use of it, obviously, as everyone has alluded to. But in speaking of harm reduction, preventing a patient from leaving the hospital with a dangerous infection because they're in withdrawal or craving can be a lifesaver.
And I'll say this too, as a pep talk for other inpatient providers who aren't yet comfortable with methadone. I've got a small cadre now of hospitalists who have seen what's happened with their patients that we've done consults on. And they are now on board with this as well. They're much more comfortable prescribing methadone before they even call us to get the patient through those early stages, the first night or morning. So it's good.
That's great. We had, before we go on and make things more complicated, we see a quick question of, do you have a preference for methadone versus suboxone? Or do you overall have a preference for one of those medications for someone like this who's more kind of pure withdrawal opioid use disorder?
Well, I personally extremely more favor methadone in this situation because it is a full mu agonist opioid. It will be probably the quickest to, more almost guarantee that it's going to help some. And you don't have to worry at all about precipitated withdrawal if somehow you're misreading something about what they're going through and you give them buprenorphine and make things worse. That's my opinion.
Yeah, I would jump in and say I agree. I think I often will feel, I sort of exhale after someone agrees to methadone versus suboxone, but I do try to really make it a patient-centered decision so that I think there's people who come in with different experiences with methadone and suboxone, have different preferences, and I really try to meet patients where they're at. I think from the medical perspective, just not having to worry about precipitated withdrawal or worrying if somebody's gotten pain medications already, if it's too soon to get suboxone, I think methadone is easier. And I think, and one last thing I'll say is, I think the population we tend to see in the hospital is enriched with more severe substance use disorders, more long-standing and more treatment refractory. I think methadone is generally better treatment in general, not for everybody, for those types of patients. And I think that's what we see more of in the hospital. So I agree with you that I often will gently push that direction, but really try to keep it open-ended.
That's great. So let's make things more complicated for our specialists here. So change up the scenario a bit. So instead of a simple abscess, now you have a person who has compartment syndrome from their infection. Very painful condition, but the initial providers were worried. They looked like they were drug seeking. They were screaming out. They have addiction. I don't know that I want to give them more opioids. So they got Tylenol, they got Motrin, they got clonidine for their withdrawal. They were, in the hospital. And let's go from there. So, Ari, let's go from there. So, this is a question that comes up a lot, and it has, really some difficult parts of how do you co-manage addiction in painful conditions, and how do you keep folks safe?
Yeah, it's a great question. I mean, I think sort of a starting place, I start from where my lecture, hopefully you guys heard, which is like, this is a healing place. And so I think, historically, especially in recent years, I think the pendulum has swung backwards. And I'd say in general, we are undermanaging people's pain who have substance use disorders in the hospital. So I started to start from that place. And I think, I think you have to treat, in my mind, you have to treat both at the same time. To treat pain without treating withdrawal is not going to work very well. And to treat withdrawal without treating pain is just going to make each other much worse. And then, on the flip side, I think treating one makes the other one better. And so I think you have to treat them both. I think in this patient's case, I sort of just had said how I generally like to make it patient-centered, and sort of people want one or the other. We can go either way that people want. I think in this case, when somebody comes in with a really acute, painful issue like the compartment syndrome, I think I'm definitely going way much more towards methadone. The reason being is suboxone has some blocking component to it, and so it can be harder to get people adequate pain control if they have suboxone in their system. And so, I think thinking about this patient, I would go to see him. I'd recommend both methadone and then some IV dilaudid. This is a very painful thing, and so generally, like my starting dose is like Steve, and the average patient like we talked about first was probably 30 milligrams of methadone, and then you have a little bit of room if you need it for a little bit of acute pain management. This patient is going to need some really intense pain management, probably going to need some short-acting opioids in high doses. And so I usually shoot lower with methadone in this patient, somebody like 15 or 20 milligrams. So you're going to have more room to work with through something like IV dilaudid. And, I think another point I wanted to make about sort of treating pain and addiction in the hospital is I think it's really worth your while to invest time up front and try to get it under control. I think that later in the game, you start trying to treat these things, the more people are hyper-aroused, the harder it is to sort of get through it, and both to connect them, but also to get their pain under control. And so what I often try to do is treat it early. And so I would show up to this person's bedside and, offer to start methadone would be my recommendation, and start with a milligram of IV dilaudid. And I think the piece I want to emphasize is I think you have to do some frequent assessments. It's hard to know, people ask me sometimes, the hospital patient, what's a good dose of dilaudid for this person? Like, I don't actually know. You see people with huge differences in the amount of opioids they're using. There's, huge differences in the potency of the opioids that they're using. So it's hard to know, but I think from a safety perspective is we want to treat their pain, and we want to make sure that we're not going to cause respiratory infection. And so what I would do is give a milligram of dilaudid. We'll know the effect of that in about 20 or 30 minutes, go back and see how they're doing, have a low threshold to go up from there. So that's sort of brief, a couple of points I wanted to touch on. And then I think another sort of just theme is how do you tie in harm reduction? And so, I think all of us as providers don't want to contribute to someone's addiction. I think we all want to help and treat somebody's addiction. But I think there's a piece in medicine where I don't want to, give opioids because I don't want to be part of this issue. And the way I sort of break it down is like, I think giving somebody IV dilaudid once or twice when they're in, or 4 times or 10 times even when they're in crazy severe pain is a very low risk to, contributing to a lifetime exposure to opioids. On the flip side, if we don't treat it, there's such a high risk of them leaving AMA with compartment syndrome or an abscess or whatever it is. And so, I think we have to sort of think about that from a harm reduction approach while continuing safety. And so I tend to be more aggressive early and really emphasize the point of starting treatment and really following up at short intervals. My real experience is if you can get under control early, you're able to have those conversations with patients. They see that you're working with them, not everybody. And I think the conversations around tapering and transitioning to oral opioids tend to go much better. So that's sort of a general thing. And I think always good to include non-opioid pain medications, multimodal things as well.
Great. We have a bunch of questions, and obviously from this, because I think this is something that a lot of folks think about. One of them specifically is the person who's on suboxone and may have a painful condition. And how do you approach that? Do you continue? Do you stop? What are you doing to treat this person with compartment syndrome who walks in on 16 of suboxone?
It's a good question. I mean, I think there's always the question of like, what do we do with the suboxone dose? And maybe we can take a couple of different scenarios, but start with the first scenario. So like this guy has compartment syndrome. It's a surgical emergency. So hopefully he's going to go to the OR within a matter of hours. And so probably by the time we get around to him ordering and receiving the suboxone dose, I think we're probably going to be able to discontinue it. And so a couple of points on that. So like ideally, like this person comes in with suboxone, you have to be aggressive with IV opioids. While suboxone is a blocker, you can get through it. And so I tend to just choose more higher potency, but also higher affinity medicine. So dilaudid is also one I like in these scenarios because it has pretty high affinity and can better get through that blockade. And so I think you need to treat aggressively. If somebody's on suboxone, you can give them some pain relief. Maybe not quite the same as if they weren't on suboxone, but I think there is a thought out there that if somebody's on suboxone, you can't give opioids. You absolutely can. You probably just need to give more. I think the other thing, probably the most important thing for this particular patient is he needs to go to the OR. And ideally, anesthesia is thinking about this already, but they need a regional block. And so I think that probably the biggest saving grace here is if you can get a regional block. that'll get you through the night for pain relief, in addition to whatever short-acting opioids we need. And then by the time his suboxone dose is due the next day, we can just resume it. Having said that, both for methadone and suboxone, I think, there's some, a lot of people respond well to split dosing. So you might take a suboxone dose, I can't remember if outpatient dose was, but split it, they're either Q8 hours or Q12 hours. The pain relieving qualities of it tend to be shorter acting than the opioid suppression piece. And so I think that's one scenario. This guy, I think we're just going to treat his pain aggressively with Dilaudid and get an operation. But I think there's another spectrum of people, whether it's, on the other end of the spectrum would be somebody coming in for an ambulatory surgery. And how do you handle their suboxone if they're going for a hip replacement? And that tends to be also a patient-centered decision. And I think there's a couple of themes that you want to try to balance. One is like how confident you are that you can control their pain, i.e. how painful the procedure is going to be, and then how easy is it to get them back onto suboxone. So I don't take stopping suboxone lightly because for a lot of people, they've had a hard time getting back on it. So I don't take it lightly. And in my experiences, I think, except for very, very, very painful conditions and painful surgeries, we can keep people on suboxone and treat through it. One thing that you can do is if you know it's going to be an ambulatory surgery is to try to reduce the dose. So it is a dose-dependent blockade. So try to get somebody down to like 4 milligrams BID. The day of the surgery can help you get your pain control underway.
I want to open it up to others if others have thoughts. And we do have a couple questions specific to this, which I can bring up.
Yeah, the only other thing I would add would be sometimes the team is very excited about stopping the suboxone entirely. And a lot of times what we do, especially if they're not on super high doses starting off, is to always keep them on a little bit of suboxone, even 2, maybe 4 milligrams. It really seems to make it a lot easier to get them back on the regular doses later in the hospital stay without precipitated withdrawal. That seems to help quite a bit. And the only other comment on this scenario was that thing about the drug-seeking behavior mentioned up above. I know it's not exactly the question, but boy, I would try to do some education to the people around what those kinds of comments. And if you do it right, it's taken well. We don't blame the diabetic for drug-seeking their insulin when the sugar's 400. So, similar to all the other things we were talking about earlier about stigma and bias. So that's an educational opportunity.
Yeah, I think it's a really important point, and it actually gets to one of the questions here as far as using what you use, and do you try to avoid Dilaudid or hydromorphone because it's known to be more euphoria and go for morphine, and it kind of gets into a really hard part, I think, as providers where, on the one hand, we know that for opioid naive patients that the opioids we give run the risk of addiction. And I think for a lot of us transitioning to, know this person is at the end of their addiction. They have endocarditis, and if they walk out, they're going to die. And so what do you do? Do you worry as much about the euphoria from hydromorphone and maybe do morphine? What is your practice on that?
Yeah, I'll take that first. I think it's a balance between the condition that you're treating. So maybe, like the first case scenario, somebody comes in with an abscess, like it's painful, but it's not compartment syndrome. And so I would choose, something else besides Dilaudid in that scenario. I think in the case of this patient, I tend to use Dilaudid because this is a severe pain, and I'm much less worried, comparatively about the euphoric aspect of it than I am about them just having humane pain control. So I think you sort of, there's a spectrum there, and I think it's trying to balance those two things. And I think overall, in the spectrum of someone's long history of addiction, I'm not so worried about the few Dilaudid doses they get with us.
Yeah, I agree. I mean, a lot of times if you've got something that's really seriously painful or life-shortening in a dramatic way, I've actually uttered the words, quote unquote, I don't really care right now about their addiction, unquote. I mean, I really do. But, to impress upon other providers, don't worry about that so much right now. Let's just focus on getting this guy or gal under control, getting the pain under control, getting the withdrawal under control, and then we'll worry about the addiction piece later. Let's just get them through this hospital stay and maybe save their life and keep them engaged.
Yeah, I think that's great. I think that's great advice, really, because it can be, as you said, I mean, that can be life-saving, not only building their trust, but keeping them where they feel safe in the hospital. I want to switch a little bit because I want to get to a slightly different case that, again, gets at a common problem. So take another patient, a 45-year-old female, schizophrenia, anxiety, substance use disorder, admitted for a fever, injects 4 bags of heroin a day, non-compliant with most medications, Remeron, Seroquel, clonazepam. She was on methadone before, maybe it helped. She's in moderate discomfort, but also she's kind of disorganized and maybe having some hallucinations. It is really common, the co-occurrence of substance use disorder and comorbid psychiatric diagnoses. And really, I think a scary thing for more generalists are these multiple medications. And what do I do? What do I consider? How do I balance this aspect? And I wonder, Jay, if you could talk about that a little bit.
Yes, it's a wonderful case as it highlights a not uncommon scenario and an opportunity to bring up a lot of different points. It also gives me an opportunity just to say that there are no mental health diagnoses like schizophrenia that preclude us from throwing the entire arsenal of substance use treatment to the patient. And that's really important. Patients with schizophrenia, patients with mental health illness, they already are victims of bias and stigma. And then when you throw a substance use disorder on top of that, we have to be really careful our approach has to be really careful to make sure we are providing them with the full gambit of treatment. A patient with schizophrenia might be on antipsychotic medications, not uncommon to be on something like risperidone or olanzapine. And those, one issue with the class of antipsychotic medications is that they can prolong the QTC interval. They all can. And not to get too technical in this, because I know we're really focusing on harm reduction. It is just important to know that methadone also can potentially cause QTC prolongation. And the QTC interval is just a normal interval in the cardiac rhythm, and it can be measured very easily with an EKG or a rhythm strip. And it's just something for providers, especially inpatient providers, to be aware of, that your patient with schizophrenia who might be on an antipsychotic, who may benefit from methadone, you want to get that EKG and check that interval to make sure it's safe to start that treatment. You don't have that issue with buprenorphine, and this may be a subgroup of patients where buprenorphine might be a safer option. But I'd still like to emphasize offering the full measure and having discussions with these patients about that. In addition, patients who may suffer from anxiety or panic disorders, they may be on benzodiazepines. And this was brought up a little earlier today. Benzodiazepines and opiates can synergize and can cause respiratory depression when they synergize. The patients who are really, I think, we need to pay attention to here are those who may have zero tolerance to one or the other, and maybe naive to one or the other medications. It's always a good rule of thumb to treat. When providers get afraid to treat things, that's where they get into trouble. But if you have a patient who takes clonazepam or lorazepam daily, and you want to introduce something like methadone or buprenorphine, you do want to educate them and potentially think about reducing a benzodiazepine down the road. If you determine that their anxiety may be more of an issue with having a substance use disorder. So it's not a contraindicating to treating either. It's just something to be aware of and to be careful as we move forward. I want to be very careful not to caution people to treat. I think for providers, it can be easy to say, I'm not going to go near that because I'm kind of scared to approach that, and it leads to undertreatment of pain or other issues, as we just talked about. But it is important to keep these things in mind as you think about the totality of this patient's treatment. Another scenario that we sometimes see that's brought up in this case is the patient was on methadone and they've been off it for an undetermined amount of time. You want to be very careful not to just start the patient back on their old dose of methadone. And I know a lot of providers know this, and I'm preaching to the choir, but it's just another thing to be very careful about. If a patient was on 100 milligrams of methadone and they've been off it for 6 months, we do not restart at the home dose that they may be telling us. Again, probably preaching to the choir with this crowd, but just good to know for inpatient providers. Always safe to start low and work your way up as you're confirming a current or an older dose of methadone. But I think, again, the point to drive home still is patients who suffer from mental health illness already are victims of stigma, and we don't want to compound that by also not treating their substance use disorder. So it's really important to consider that and to know that there are no contraindications to doing so.
I think that's great advice, and great advice overall. Not to be, there is that fear and almost that if I don't do anything, I'm not going to get in trouble. But overcoming that to say, maybe not, but your patient will maybe get into trouble. I think that's great advice. We unfortunately only have a couple minutes left. So I kind of wanted to give an opportunity. You have I think a pretty captive audience of folks who aren't addiction specialists, but want to help. What would be maybe one of the tips you would give as far as for patients in the hospital, or maybe a common mistake someone would want to avoid? What would be your pearl of wisdom for the audience here?
Quick one that comes to mind for me is maybe just find a mentor or a buddy. I want to offer myself as that. I think if you're excited to jump in and do this, it's not that hard. It's a lot easier if you have somebody to talk it through. And so I think if there's somebody available in your institution that you can reach out to, or somebody available in the community you can reach out to, I think it's really great to have a buddy or somebody to talk cases with, and volunteer myself for that.
Thanks, Art.
Just one tip that I would have, because I see this happen a lot, it's about opiate screens. When patients come into the hospital and the ER or the admitting doctor orders an opiate screen, generally speaking, that just detects opiates, and it doesn't detect synthetics and semi-synthetics, at least not consistently, like fentanyl and oxycodone and buprenorphine and methadone. So a lot of times they'll see opiate screen negative. Great, we don't have to worry about any opioids. Everything's cool. The guy's not using anything. When in fact, that could be extremely wrong. So some hospitals are set up, unfortunately not Baystate yet, although I've been beating my head against the wall for a while, trying to get it linked somehow, or a disclaimer or something, but we're getting there. But for places where you don't have anything telling you that or reminding you that, I think it's important for people to consider, if you're worried enough about a patient's intoxication and what they've been taking, and you're worried enough to order an opiate screen, you should at least add the 4 most commonly used diverted street drugs out there, including buprenorphine, methadone, oxycodone, and fentanyl, because sometimes you get some nasty surprises that you wish you knew earlier.
Thanks, Steve. Jay, what is your pearl of wisdom?
I think it's one of the greatest things you can do is be mindful of your own feelings before you walk in the room. Be mindful if you're feeling frustrated or angry before you walk into the room. Take a second to take your pulse, catch your breath, ask yourself what's going on, and take your own sort of emotional temp before you walk in the room. The patients will pick up on this if you're feeling frustrated or anything else, and it can get in the way of care. It's been said a lot of times now you want to establish that therapeutic relationship any way you can, and reading a chart could bring up feelings before you go in the room. Be mindful of that. Take your temp before you walk in. and pull up a chair and sit down with the person. It can make a world of difference.
That's great. Dr. J. Kilpatrick, Dr. Ari Kriegsmann, Dr. Steve Ryzewicz, thank you so much for talking with us tonight. We really appreciate it.
Thank you.
Thanks for having us.
Everyone.
Thank you.